My name is Sarah Damagy, and today we're talking about atypical hemolytic uremic syndrome, or aHUS for short. It's a rare disease that affects the blood and kidneys. And to answer some of the most searched questions online about it, I am joined by Christine Maville, a clinical nurse consultant from the NRCTC. So what is aHUS?
If we break it down, so what does it actually stand for? So atypical just means it's not the typical form of aHUS. Hemolytic means that the red blood cells are bursting and they're being broken down. Uremic tells us that the kidneys are involved and that the toxins have built up, so the patients have uremia. And syndrome just tells us that more than one thing's going on at once. But what does that really mean for patients? So what's actually happening in the body? The complement system attacks the linings of the blood vessels in the kidneys. Those linings recognise that there's been an injury and they try to repair the injury, a bit like if you cut your hand. And what happens is tiny little clots form in those tiny vessels in the kidney and cause blockages in those vessels, which means that the blood that would normally flow through freely can't anymore. And as the red blood cells try to force the way through those clots, they burst open. And so patients tend to present with anemia, so they've got a low hemoglobin. Platelets are getting caught up in these clots, so they'll have low platelets. And because the kidneys are getting congested by all of these clots, they can't do their job properly and filter the blood of toxins that we would normally then wee out. And because we can't do that anymore, because of all of these clots that have formed, patients become uremic and they often stop passing any urine at all.
And what is the cause of aHUS?
aHUS is caused by complement overactivation. So complement is an ancient part of the immune system. Its primary role is to fight infection, and our complement system is always kind of ticking over all the time. So I often kind of use an analogy to a car. So if you turn your car engine on and in your driveway and you don't go anywhere, the engine is just idling. And the complement system is like this. It's always switched on, always turning over, it's always looking for infections. In order for complement to be regulated, we need some brakes and we need some accelerators. And what causes aHUS is when there is a problem. They've either got a genetic fault, that means the brakes don't work properly or the accelerators are stuck on, or some patients develop antibodies to one of the brake proteins. But that all has the same effect of meaning that the complement system is out of control. Similarly, a car would be out of control if either of those things failed.
And how do you treat aHUS in the UK?
If a patient presents to their local kidney team unwell and that local nephrologist is looking at that patient and wondering, could this person have atypical aHUS? At that point, they would normally refer through to our service in Newcastle, which is the National aHUS service. It's a diagnosis of exclusion. And what I mean by that is that there's not one single blood test that we can do that can just be done in an instant that tells us whether you've got aHUS or you don't. So there's some blood tests that are sent to the labs when patients are referred through to us, and they're special blood tests looking at that person's genetics. So we want to understand their complement system and do they have any genetic mutations that might mean that's an explanation, or do they have factor H autoantibodies. But those tests take a few weeks to come back. So the key thing for us really at the point that the patients are referred through is to think, could they have aHUS? And if there is a suspicion that they could do, then the consultants will authorise the use of a treatment that's very effective in treating atypical aHUS. And then when we get all of the blood test results back a few weeks later, that will then determine whether that patient needs to stay on treatment in the long term or not.
And what is the age of onset for aHUS?
So for atypical aHUS, we've had very young babies, so just babies of a few weeks old who've had their first episode when they've been very, very young. And similarly, we've had patients in their 80s. So when we looked at all of our information that we've gathered for all of the patients that we've ever looked after, we know that there's a peak incidence in the 0 to 4-year-olds. And there also seems to be another peak incidence in women of childbearing years. So they're probably the two ages that we see it more often, but really we can see it any age.
So can you live with aHUS?
The short answer to that is yes, you can. If you were asking me that sort of 20 years ago, I'd have given you a very different answer. But 20 years ago, we didn't understand the causes of aHUS. The treatment was something called plasma exchange, which wasn't terribly effective. The outcomes for patients were really poor. But then we discovered the cause of atypical aHUS, and on discovering the cause of that has allowed us to find a good treatment for it. And so the patient outcomes now are really good. And we've got a number of patients who are on treatment, probably about over 200 in the UK, and they do very well, and providing that we've kind of treated them in time, and they'll have regular drug therapy and have good outcomes.